Good evening, Dr. Phil here. Today we'll be discussing on traumatic brain injury. What is traumatic brain injury? TBI is an insult to the brain which occurs as a result of an external mechanical force. What do you know about the epidemiology of TBI? TBI is one of the leading causes of death worldwide and is estimated at affecting 50 to 60 million people annually. It is the leading cause of disability in patients under 40 years old. Approximately one-third of patients presenting with TBI have polytrauma. Non-accidental injury should be considered in children. There's a tendency towards bimodal distribution, TBI in young adults due to road traffic collisions and TBI in elderly due to falls. What is a primary brain injury? A primary brain injury refers to neuronal damage which occurs immediately as a direct result of initial trauma. It is irreversible. Mechanisms include impact, inertial loading, penetrating, and blast. What is the pathophysiology of primary TBI? Deformation of tissues due to compression, tension, and/or shearing forces results in direct neuronal cell damage via local inflammation, vasogenic edema, cytotoxic edema, interstitial edema, and impaired cerebral autoregulation. Can you describe the types of TBI? This includes fractures, simple skull fracture, which does not penetrate the dura, may result in EDH or SDH. Depressed skull fracture, most likely to result in dural tears and damage to the parenchyma. Hematomas, EDH, SDH, intraparenchymal hematoma, SAH, and intraventricular hemorrhage. Other types of TBI includes contusion and diffuse axonal injury. What is blunt cerebrovascular injury? This is a non-penetrating injury to the major arteries supplying the brain, such as carotids and vertebral arteries. Weakened vessel walls may lead to intimal tearing, thrombus formation, wall hematoma, and lumen occlusion. Pseudoaneurysm may also occur. Ischemic stroke is a major complication. Use of the expanded Denver screening tool is recommended before investigation with CT angiography. Management centers on antiplatelet or anticoagulant therapy with or without endovascular intervention. What is secondary brain injury? This refers to neuronal damage due to sequelae of primary injury. This occurs hours to days after the primary injury and is the main determinant of outcome. What are the main physiological and cellular changes associated with secondary brain injury? Primary injury may exhaust the compensatory capacity of the brain towards raised ICP, leading to increased ICP, reduced cerebral perfusion pressure, cerebral ischemia, and hypoxia. Other changes in secondary brain injury includes excitotoxicity, vasogenic fluid accumulation, loss of cerebral autoregulation, and seizures. What are the causes of secondary brain injury? Intracranial causes include hematoma, expansion or rebleed, hydrocephalus, vasospasm and delayed cerebral ischemia, intracranial infection and seizures. Extracranial insults includes hypoxia, hyper or hypocapnia, hypotension, hyponatremia, hypo or hyperglycemia, hyperthermia, and infection. How can one grade the severity of TBI? GCS is the most widely accepted tool for grading severity of TBI. Mild TBI, GCS 13 to 15, moderate TBI, GCS 9 to 12, severe TBI, GCS less than 8. How would you assess a patient presenting with TBI? This would be time critical and should follow trauma resuscitation principles. Focus history includes patient age, medical history, allergies, and medications including antithrombotic therapy. Injury mechanism, GCS, at the scene and on arrival, seizure activity and other injuries, and management thus far. Examination, vital signs, primary survey, GCS, pupils, focal neurological deficit, and signs of herniation, such as cranial nerve palsies, fixed dilated pupils, Cushing's reflex, and diabetes insipidus. Investigations includes bedside ABG, focused ultrasound, and ECG. Laboratory, trauma blood panel, coagulation profile, group and safe, cross-match, CT imaging, a polytrauma PAN scan may be indicated, and X-rays. When would an emergency CT imaging be indicated? CT head imaging should be performed within 1 hour with any of the following risk factors: GCS less than 13 on initial assessment in the ED, GCS less than 15 at 2 hours, suspected open or depressed skull fracture, signs of basal skull fracture such as hemotympanum, panda eyes, CSF leak, and battle sign, post-traumatic seizure, focal deficit, and more than one episode of vomiting. When is neurosurgical referral indicated in TBI? This includes presence of new or surgically significant abnormalities on imaging, GCS 8 or less after initial resuscitation, unexplained confusion lasting more than 4 hours, deterioration in GCS after admission, progressive focal neurological signs, seizures without recovery, definite or suspected penetrating injury, and CSF leak. Which patients should receive ICP monitoring? Brain Trauma Foundation guidelines suggest ICP monitoring in moderate to severe TBI, i.e. GCS less than 12 who cannot be serially neurologically assessed, for example if sedated, any severe TBI with an abnormal CT head scan, and any severe TBI with a normal CT head scan if two of the following are present: age more than 40, systolic blood pressure less than 90 mmHg, and abnormal motor posturing. Methods for ICP monitoring includes via clinical features such as decreased consciousness level, papilloedema, Cushing reflex, dilated pupils, headache, vomiting, seizure, and ECG changes, and via invasive methods such as EVD and intraparenchymal ICP monitoring. This table comparing EVD versus intraparenchymal ICP monitor is included here for completion. Can you describe the physiological principles used to prevent secondary brain injury? This includes maintaining cerebral oxygen supply via normoxia, CPP 60 to 70 mmHg, and treating anemia, reducing CMRO2, such as via deep sedation, paralysis, seizure management, ensuring normothermia, normal glycemia, and barbiturate infusion, managing raised ICP via ICP monitoring, increase cerebral venous drainage, bed tilt or head up to 30 degrees, head in alignment, C-spine protection, no tape eyes and loose tube ties, reduce intracranial blood volume by low normal PaCO2 and surgical evacuation of the lesion, CSF drainage via EVD, and osmotherapy to reduce parenchymal swelling, decompressive craniectomy to remove volume or pressure limitation. How would you manage a patient presenting with TBI in the pre-hospital and ED setting? Initial management relies on timely interventions and transfer to a neurosurgical center. Management of TBI focuses largely on prevention of secondary brain injury. Appropriate interventions include pre-hospital, management of life-threatening injuries, C-spine protection, airway protection. Indications for intubation is included here. Breathing, maintain oxygenation, ventilation, short-term hypocapnia if signs of raised ICP, circulation, IV isotonic crystalloid fluid resuscitation, tranexamic acid and osmotherapy. At the ED level, trauma primary survey, transfer to CT scan once stable, may require emergency operation for stabilization and damage control, secondary survey, osmotherapy when indicated, tranexamic acid and major hemorrhage management where relevant. Definite treatment determined by lesion, destination either theatre, ICU depending on findings. Some patients may be appropriate for extubation following CT scan. AAGBI checklist for transfer of adult neurosurgical patients is included here for completion. What is a good outcome from TBI? Based on assessment via extended Glasgow outcome scale, 5 to 8 is favorable, 1 to 4 is considered unfavorable. How would one manage a patient presenting with TBI in the intensive care setting? Management of TBI focuses largely on prevention of secondary brain injury and should follow a tiered approach. Repeat imaging should be considered at each tier. Multimodal monitoring should be considered. Surgical intervention may be required in the form of EVD, evacuation of mass lesion, and decompressive craniectomy. SIBICC, Severe TBI Algorithm for Patients with ICP Monitoring. Principles for using tiers. When possible, use lowest tier treatment. It is not necessary to use all modalities in a lower tier before moving to the next tier. There is no rank order within a tier. If considered advantageous, tier can be skipped when advancing treatment. Between each tier, re-examine the patient and consider repeat CT scan. Reconsider surgical options for surgical lesions. Review that basic physiological parameters are in desired range. Consider consultation with higher level of care if applicable. Tier 0, ICU setting management, endotracheal intubation and mechanical ventilation. Keep SpO2 94% or more, EtCO2, outline, CVL, CPP monitoring. Keep CPP 60 mmHg or more. Optimize head's venous return. Head of bed elevation 30 to 45 degrees. Keep HB 7 grams per dl or more. Serial neuro and pupil evaluation. Analgesia and sedation. Anti-seizures for 1 week. Avoid hyponatremia and avoid temperature more than 38 degrees Celsius. Tier 1, PaCO2 keep between 35 to 38 mmHg, CPP 60 to 70 mmHg, increase analgesia and increase sedation, osmotherapy with mannitol or hypertonic saline, EVD CSF drainage, continue anti-seizure, consider EEG monitoring. Recommended sodium and osmolarity limits are 155 MEq per liter and 320 milliosmol per kg respectively. With increasing ICP, Tier 2 treatment includes keep PaCO2 32 to 35 mmHg, paralyze the patient, MAP challenge to assess cerebral autoregulation, increase cerebral perfusion pressure with fluids, vasopressors or inotropes if autoregulation is intact. Continuous neuromuscular blockade should only be proceeded when efficacy is demonstrated. Tier 3 therapy includes barbiturate coma, decompressive craniectomy, and mild hypothermia 35 to 36 degrees Celsius. Barbiturate coma should only be continued when a beneficial effect on ICP is demonstrated. Hypotension must be avoided when barbiturates are used. The technique for MAP challenge is included here for completion. If there is impaired autoregulation, adjust the target MAP back to baseline. If there is intact autoregulation, adjust target MAP to chosen new elevated target. Critical neuro worsening is defined as a serious deterioration in clinical neurological status, which requires an immediate physician response, such as spontaneous decrease in GCS motor score of 1 or more, new decrease in pupillary reactivity, new pupillary asymmetry or bilateral mydriasis, new focal motor deficit, herniation syndrome or Cushing's triad. Management include emergent evaluation to identify possible causes of neuro worsening. If herniation is suspected, empiric treatment includes hyperventilation and bolus of hypertonic solution. Consider emergent imaging or other testing, and rapid escalation of treatment. Causes of critical neuro worsening includes expanding intracranial mass, medication effect, cerebral edema, impaired renal or hepatic function, substance withdrawal, dehydration, hyper or hypothermia, elevated ICP, stroke, electrolyte, metabolic disturbances, medical comorbidity, hypotension, seizure, hypoxia, CNS infection, or sepsis. Treatments that are not recommended includes mannitol by non-bolus continuous IV infusion, scheduled infusion of hyperosmolar therapy, lumbar CSF drainage, furosemide, routine use of steroids, routine use of therapeutic hypothermia due to systemic complications, high-dose propofol for burst suppression, prolonged hypocapnia, and routinely raising CPP above 90 mmHg. Other management priorities includes consider cardiac output monitoring and echo due to myocardial stunning from catecholamine release, closely observe for polyuria, subcute desmopressin 1 to 2 mics for diabetes insipidus, consider screening for hypopituitarism. A recent trial, HeMotion in 2024, compared restrictive versus liberal transfusion strategy and found that liberal transfusion strategy did not reduce the risk of an unfavorable neurologic outcome at 6 months. Is there a role for decompressive craniectomy in TBI? Decompressive craniectomy is controversial and not without significant risk of medical or surgical complications. The operation does take place occasionally, often as a last resort. Optimizing medical management may reduce the need for decompressive craniectomy. Mortality reduction might be offset by significantly higher survival with other unfavorable outcomes. RCTs that have examined the role of decompressive craniectomy includes the DECRA trial in 2011, patients with TBI with refractory intracranial hypertension, intervention, decompressive craniectomy versus medical therapy, primary outcome, 6 months GOSE, no difference in mortality, unfavorable score 1 to 4 is significantly higher in patients undergoing decompressive craniectomy. Secondary outcomes such as hours of intracranial hypertension, days of mechanical ventilation, ICU length of stay is significantly lower in the decom craniac group. Another trial, the Rescue ICP 2016, patients with TBI, abnormal CT and refractory intracranial hypertension are included, intervention, decompressive craniectomy versus medical therapy, primary outcome, 6 months of GOSE. There is lower mortality but higher disability. 12-month GOSE scores are similar. Is there a role for steroids in TBI? Corticosteroids have been linked to worse outcomes and are not recommended in TBI, based on the results of CRASH trial 2004. Additional notes: CRASH 1 trial showed that steroids increased mortality and morbidity in TBI. CRASH 2 trial showed that tranexamic acid reduced the mortality in major trauma, RR of 0.91. CRASH 3 trial showed that tranexamic acid reduced mortality in mild to moderate TBI, risk ratio of 0.78. Is there a role of therapeutic hypothermia in TBI? Therapeutic hypothermia has not been demonstrated to improve outcomes and carries significant morbidity such as infection. Its use is not recommended. Landmark trials include Eurotherm 2015 and Polar Trial 2018. How can patients with TBI be neuroprognosticated? This is a difficult task. This should be undertaken after a period of stabilization, accounting for a variety of factors. Consensus opinion of multidisciplinary team discussion is required. Clinical predictors to consider includes age, GCS post-resuscitation, motor component of GCS post-resuscitation, pupillary reactivity to light, pupillary size, intracranial injury type, raised ICP, hypoxia, hypotension, and significant comorbidities. Radiological predictors based on Marshall classification of CT imaging and MR head imaging. Research-based predictors includes MR spectroscopy, EEG, SSEP, and biomarkers such as serum S100B, NSE, IL-10, and protein degradation products such as tau, amyloid, and gliofibrillary acidic protein. What are some anesthetic considerations in patients with TBI undergoing non-neurosurgery? Ensure neuroprotective management goals are met during anesthesia to prevent secondary brain injury. There is no evidence to specify the exact and safe time following TBI for elective surgery. Currently, there are no contraindications to anesthesia in TBI. Steps should be taken to prevent secondary brain injury. Airway. Early tracheal intubation if GCS is less than 8 or unable to maintain respiratory goals. Ensure cervical spine protection. Avoid nasotracheal intubation in base of skull fractures. If on tracheostomy, ensure that it is cuffed for intraoperative mechanical ventilation. Avoid hypoxia. Maintain PaCO2 in the normal range. Avoid prolonged hypocapnia. Hyperventilation is a temporizing measure to prevent impending herniation. Lung protective ventilation, as 20% of TBI patients have ARDS. The level of PEEP should be adjusted such that increasing PEEP does not increase ICP. Avoid hypotension. Maintain MAP more than 80 mmHg. Replace intravascular volume. Avoid hypotonic solutions. Vasopressor agents as necessary to maintain cerebral perfusion pressure. Systolic blood pressure target should be 100 mmHg or more in 50 to 69 years old and 110 mmHg or more in 15 to 49 years old and in those 70 years old or more. Transfuse blood products as indicated. Reverse existing coagulopathy. Keep HB more than 7 grams per deciliter. Consider tranexamic acid when indicated. Induction agents for anesthesia. Propofol and thiopental reduces CMRO2, which is beneficial in preventing secondary brain injury, provided that their hypotensive effects are avoided. Etomidate has limited effect on MAP and is advantageous in maintaining CPP. However, its adrenal suppressive effects increases mortality in septic patients. Ketamine has been proven to be neuroprotective, and there are no evidence of harm based on a recent review by Gregors et al. In 2020. Anesthesia for maintenance. There is no evidence to indicate that TBI outcomes can be improved based on the type of anesthetic agent used. Maintenance of anesthesia may be accomplished using either inhaled or IV anesthetics, with careful control of hemodynamic management goals. Avoid ICP more than 20 mmHg, maintain CPP 60 to 70 mmHg, adequate sedation and analgesia, treat seizures. In raised ICP, treatment includes hyperosmolar therapy, muscle paralysis, CSF drainage, barbiturate coma, decompressive craniectomy, and mild hypothermia. Metabolic goals includes maintain euglycemia, avoid hyperthermia, DVT prophylaxis, avoid steroids. A summary of the recommendations related to anesthetic management from Brain Trauma Foundation Guidelines, 4th edition, is included here. These are my references. Thank you.